This session, we're going to see about drugs for treating asthma and cough. So, asthma is a chronic hypersensitivity reaction of the bronchus, which leads to bronchoconstriction and difficulty in breathing. Okay, so we'll see about asthma and cough in this session. So, asthma is a hypersensitivity reaction to the airway, okay, because of a stimulus that can be an endogenous stimulus or an exogenous stimulus, like dust, allergen, pollen grains, mite, anything could be an allergen, even smell of some food substances. All these things could be allergens for triggering an attack of asthma. So there is spasm of the airway smooth muscle along with airway edema and secretion of thick mucus and bronchoconstriction. Okay, so this is because of an antigen antibody reaction and release of autocoids. So these autocoids are in the chapter prostaglandins, leukotrienes, and platelet activating factor. In that chapter, autocoids have been dealt in detail. So here these autocoids like histamine, kinins, and leukotrienes, they are the main culprits in causing the bronchoconstriction. Okay. So there are two types of asthma. Extrinsic asthma, which occurs at early age. There are episodal attacks of asthma, and there is a presence of a family history. Intrinsic asthma usually happens in the middle age with no family history. So before moving on to the drugs, we'll see what happens, what pathophysiological changes take place in the lungs when there is an attack of asthma. Okay. So normally when there is an allergen, now this is the mast cell. Okay. This mast cell contains histamine inside it. So when the patient gets an allergy for the first time, okay, an antibody gets produced against this allergen, which is an IgE antibody. Okay, so this antibody comes and sits on the mast cell. So this is the antibody, IgE antibody, which is present on the mast cell. Mast cell contains histamine inside it. So when the patient gets the stimulus of the allergen for the second time, this allergen comes and attaches itself to the antibody which is already synthesized and is present on the mast cell, and this mast cell opens up. This mast cell opens and releases the histamine. Okay, this histamine is an inflammatory mediator which will cause chemotaxis of all the other inflammatory mediators. This is one side. Another side, what happens is there is an allergen, no? It's gonna break open the cell membrane. So when the phospholipid bilayer breaks open, this is the bilayer, phospholipid of the cell membrane. It produces arachidonic acid by phospholipase enzyme. Okay. This arachidonic acid gets acted upon by something called as LOX, lipooxygenase enzyme, and produces the leukotrienes. Okay, so these leukotrienes will go and act on their specific receptor and trigger the bronchoconstriction. This is what normally happens. So now we'll take, this is the bronchus cell. Okay, bronchus muscle cell, bronchial muscle cell. This is one particular cell. So this cell contains few receptors like M3, beta 2, LT. LT means leukotriene. Okay. So now what happens? This is all we're talking in the pathophysiology. Normally when an attack of asthma happens, what happens? So whenever muscarinic receptors are stimulated, normally when they are stimulated, they will cause bronchoconstriction. Okay, when they are stimulated, they will cause bronchoconstriction. Similarly, leukotrienes, when they get produced in an allergic response, when they act upon their specific leukotriene receptor, which is present on the bronchial cell, they also cause bronchoconstriction. Okay. Beta receptor. When beta receptor, which is present on the bronchial smooth muscle, is activated, what will happen is they will increase cyclic AMP, okay, which causes bronchodilation. Okay, so this cyclic AMP gets degraded into 5-AMP by an enzyme called phosphodiesterase. In short, we can write this PDE. So this is the pathophysiology of what happens in a bronchial smooth muscle when there is an attack of asthma. So what happens? Whenever there is an allergen, the IgE antibody which is already produced is sitting on the surface of mast cell. This mast cell contains histamine inside it. So when the same allergen comes for the second time, it gets attached itself to the IgE antibody which is on the surface of the mast cell, and this mast cell will open up and release the histamine. Histamine, being an inflammatory mediator, will cause chemotaxis and recruitment of all the other inflammatory mediators. This is one side. Okay. Other side is this allergen is going to act on the phospholipid bilayer of the cell membrane. This enzyme phospholipase will act on the cell membrane and release arachidonic acid. AA is arachidonic acid. This pathway has been dealt in the chapter prostaglandins, leukotrienes and platelet activating factor. You can refer to that chapter. So arachidonic acid gets acted upon by lipoxygenase enzyme and produces leukotrienes. These leukotrienes act on the specific receptor which is present on the bronchial smooth muscle and cause bronchoconstriction. Two other receptors which are involved are cholinergic receptor M3. When that gets stimulated, it's going to cause bronchoconstriction. And beta-2 receptor, it is actually good. No, beta-2 is good one because when it gets stimulated, it increases cyclic AMP which causes bronchodilation. This cyclic AMP gets degraded into 5-AMP by phosphodiesterase enzyme. So this is the pathophysiology. Now what we want to do, we want to prevent an attack of asthma or treat an attack of asthma. Correct. So now if we modify the drugs or the receptors that are present here in this pathophysiological process, then we can ultimately treat asthma. So to classify drugs that are used in the management of asthma, bronchodilators. Okay, bronchodilators means what? From the name, they dilate the bronchus. Sympathomimetics, that is beta-2 agonists. They are nothing but beta-2 agonists. Salbutamol, terbutaline, salmeterol. METHYLXANTHINES, theophylline, aminophylline. Anticholinergics, ipratropium bromide, tiotropium bromide. LEUKOTRIENE antagonists, MONTELUKAST, ZAFIRLUKAST. MAST cell stabilizers, sodium chromoglycate, ketotifen. Corticosteroids, which can be given via two routes, systemic route or inhalational route. Systemic route includes hydrocortisone, prednisolone. Inhalational route includes beclomethasone dipropionate and budesonide. The last one, anti-IgE antibody, which is omalizumab. Okay. So these are the drugs that are used in the management of asthma. So why the name bronchodilators? Because these drugs act on the receptors or on some enzymes which are present inside the bronchus. That is why they are called as bronchodilators. So we'll see each one of them separately. Sympathomimetic drugs, they are nothing but beta-2 receptor agonist. Beta-2 receptor. Okay, because beta-2 receptor is present in the lungs. The selective beta-2 receptor stimulant, it activates the bronchial beta receptors and it increases the cyclic AMP levels. These increased cyclic AMP will decrease the intracellular calcium level, thereby causing relaxation of the bronchial smooth muscles. The adverse effects of beta agonists include tachycardia, insomnia, oliguria and hypokalemia. So this is the bronchial smooth muscle, right? We saw now. It contains a beta-2 receptor. So when this gets stimulated, it will increase the cyclic AMP. This cyclic AMP will cause bronchodilation. Okay. So these are the drugs under beta-2 agonists. Salbutamol, the dose is 100 to 200 micrograms. It has got selective beta-2 receptor agonists and it acts for a period of 4 to 6 hours. Terbutaline, the dose is 250 to 500 micrograms. It is also a beta-2 selective drug and it also acts for a period of 4 to 6 hours. Clenbuterol, the dose is not known and it has a duration of action of more than 12 hours. Phenoterol has a dose of 200 to 400 microgram and the duration of action is about 4 to 8 hours. And salmeterol, the duration of action is about 12 hours. So clenbuterol and salmeterol, they are long acting. Okay. whereas salbutamol and terbutaline are short acting. Okay. The next group, methylxanthines. Now we saw no, in the bronchial smooth muscle, beta 2 receptors are present. When they get stimulated, they will increase the cyclic AMP. This cyclic AMP will get degraded into 5-AMP by an enzyme called phosphodiesterase. This cyclic AMP only causes bronchodilation, right? So we want the cyclic AMP to be present. We don't want cyclic AMP to get metabolized. So these drugs, the methylxanthines, what they do is they will inhibit this phosphodiesterase enzyme. So what happens? Cyclic AMP will not get metabolized. It's present in the higher levels. Increased levels of cyclic AMP is available. Thereby it causes bronchodilation, which is actually what we want. The other action is they also inhibit the release of other inflammatory mediators. Some of the adverse effects of these drugs include nausea, vomiting, epigastric pain, stimulation of gastric secretion, headache, tachycardia, hypotension, and in the CNS it can cause respiratory stimulation and insomnia, and in toxic doses it can cause seizures, agitation, premature ventricular contraction and emesis. So in order to treat the seizures, we will give intravenous diazepam to control the seizure episode. Moving on to anticholinergics, now we know in the bronchial smooth muscle, M3 receptors are present. When they get stimulated, they cause bronchoconstriction. Now anticholinergics, what they will do? They will block the receptor. Which receptor? M3 receptor. So what will happen? It will cause bronchoconstriction will not happen. It will cause bronchodilation. They are effective bronchodilators. They inhibit competitive inhibition of the M3 receptor which is present in the bronchi. They are useful in patients who are intolerant to beta agonists, and they are also used in the treatment of chronic asthma or asthma that is refractory to other drugs. For those patients who did not have adequate response with other drugs used in the treatment of asthma, this drug can be tried. Steroids. Now we saw when these allergens will act on the phospholipid bilayer. The first picture, if you remember, phospholipid layer gets acted upon by phospholipase enzyme, which produces the arachidonic acid. Now steroids, what they will do is they will inhibit this phospholipase enzyme. Thereby arachidonic acid does not get produced. From arachidonic acid only the other inflammatory mediators are getting synthesized. So if you block the first step itself, the inflammation will not progress. So that is what corticosteroids will do. They inhibit the release of arachidonic acid from the cell membranes, which is a first step in the formation of eicosanoid products, that is prostaglandins and leukotrienes. And they also decrease the antibody formation in the first allergic reaction itself. They also decrease the release of mast cell, the histamine from the mast cell, and they decrease bradykinins and prostaglandin formation. So basically they are very good. They block the first step in the inflammation reaction itself. So this is going to be very, very effective. But there are some severe adverse effects when this drug is given for a long duration of time. In chronic use, they can be given along with another bronchodilator. Steroids will have a very efficacious response when they are given along with the other bronchodilator. So some of the adverse effects include oropharyngeal candidiasis because it can reduce the immunity. So when it is given as an inhalation, the drug particles will stay in the oral mucosa, and in the oral mucosa, if the immunity goes down, the opportunistic candidiasis can come and have the infection because of reduced immunity. It can cause adrenal suppression when there is systemic absorption. So it shouldn't be given for a long duration of time, only for short duration. Only short duration only it should be given. It can cause infiltration of eosinophils into the lung. So these are some of the adverse effects of corticosteroids. So it has to be always combined with another bronchodilator. It has to be given for the shortest possible time. So in order to prevent this oral candidiasis, you have to advise the patient to rinse the mouth after every time they use this inhalation. Mast cell stabilizers. So in the first picture we saw, this is a mast cell which contains histamine. When it is triggered, it opens and histamine gets released. So now from the name itself, mast cell stabilizers. These drugs will inhibit the release or inhibit the opening of the mast cell. They will inhibit the degranulation of mast cell, thereby inhibits the release of the mediators of inflammation. But once the mast cell is already opened, there is no point giving this drug. So this has to be given as a prophylactic agent. It's not used as a treatment of acute asthmatic attack. It has to be given as a prophylaxis, not for an acute attack, because it won't be effective because already the inflammation has started. So the side effects include drowsiness, dry mouth and dizziness. Leukotriene antagonists. So from arachidonic acid, it gets acted upon by LOX to produce leukotrienes. These leukotrienes will act on the leukotriene receptor which is present on the bronchial smooth muscle. Correct? And they will cause bronchoconstriction. So what can be done? We want to reduce the production of leukotrienes. Correct? So what can be done? First is you can inhibit this enzyme LOX so that leukotrienes doesn't get synthesized. So that drug is xylutone. Other thing what we can do is we can block the receptor. Okay, those drugs are ZAFIRLUKAST and MONTELUKAST. Okay, so we'll see here. Leukotrienes are produced by the action of 5-lipoxygenase on arachidonic acid. They produce eosinophils, basophils and macrophages. They cause bronchoconstriction and they increase the bronchial reactivity, mucus secretion and mucosal edema. All this will cause bronchoconstriction. Okay. So these drugs, ZAFIRLUKAST and MONTELUKAST, they block the LT receptor, leukotriene D4 receptor, which is present on the bronchial smooth muscle, and thereby they reduce the symptom, airway reactivity and inflammation. They reduce the frequency of exacerbations of asthma. The adverse effects include headache, rashes and GI disturbances. So what drugs should be given for which type of asthma? That is what we're going to see now. For mild asthma, you will give a short-acting beta agonist like salbutamol or terbutaline. For moderate asthma, regular prophylaxis has to be given with a mast cell stabilizer and inhaled corticosteroids. For acute episode, prophylaxis has to be given with mast cell stabilizer and inhaled corticosteroids every day. And for an acute episode, you will give a short-acting beta agonist. For severe asthma, you will give regular inhaled steroids, inhaled beta-2 agonists, oral steroids and oral methylxanthines. A combination of all 4 drugs have to be given. So this condition called status asthmaticus is a severe episode of asthma where the patient has called difficulty in breathing and even difficulty in speaking one complete sentence in one breath. So for this condition, it's an emergency condition. So for this condition, you will give nebulization with beta agonists and ipratropium bromide, which is an anticholinergic. Corticosteroids like hydrocortisone IV injection followed by oral prednisolone. Oxygen inhalation has to be given. Antibiotics if there is a coexisting infection. IV fluids in order to correct the dehydration. And last, if at all the patient is not completely able to breathe, then we have to intubate the patient and provide artificial ventilation. Moving on to cough. So cough is an explosive expiration that provides a protective mechanism to expel the tracheobronchial tree of any secretions or foreign bodies or irritants. So what happens is whenever there is an irritation, we take a deep inspiration. And there is compression of the chest intercostal muscles and there is a expulsion so that all the foreign body or secretions just get expelled out. So there are 2 types of cough, productive and unproductive. In productive cough, there is mucus production along with the cough, and along with this mucus, unwanted materials also get expelled out. In unproductive cough, there is no mucus production and it can be very dry and very harassing. So the drugs that are used to treat cough, productive cough, we have expectorants. That is, they try and mobilize the mucus so that they are excreted out. In non-productive cough, we have antitussives and pharyngeal demulcents. So antitussives, they suppress the cough center. Okay, they inhibit the cough center in the medulla, thereby the cough is getting suppressed. So these are used for dry cough. They reduce the tussle impulses in the respiratory tract as well. So the drugs under this category include opioids, non-opioids and antihistamines. Under opioids we have codeine, noscapine. Under non-opioids we have dextromethorphan, codeine. And under antihistamines we have chlorpheniramine, diphenhydramine and promethazine. Codeine. It is less potent than morphine, but the addiction liability is less with codeine. This is one of the standard antitussive that you can get, that's very commonly available. It is more selective for the cough center and can suppress cough for about 6 hours. The duration will be about 6 hours. The adverse effects include constipation, drowsiness and respiratory depression. So always advise a patient to take this syrup during the bedtime, not during daytime, because it can cause drowsiness. Contraindications: it's absolutely contraindicated in asthmatics because it can cause respiratory depression and it can have diminished respiratory reserve. Noscapine, it's a very potent antitussive. Okay, it depresses cough. It is equipotent to codeine and it is useful in spasmodic cough. The adverse effects include headache and nausea. So dextromethorphan, it is a synthetic opioid derivative. It is as effective as codeine. There is no constipation or addiction. But the adverse effect includes dryness of mouth, vertigo and irritability. H1 antihistamines, they enhance the action of antitussives and expectorants by sedative and anticholinergic actions. Okay, they have sedative property because they cross blood-brain barrier, and anticholinergic actions causes dryness of secretion. So the use in allergic cough, the drugs include, as we already saw, chlorpheniramine, diphenhydramine and promethazine. Pharyngeal demulcents. They increase the flow of saliva and produces a soothing effect on the throat. They provide symptomatic relief for dry cough, which includes lozenges, cough drops and linctuses. So moving on to expectorants, these are used in productive cough, which try and expel the contents out, that is expel the mucus out from the bronchial tree. So it increases the bronchial secretions, it decreases the viscosity of the mucus so that it is easy to expectorate out. It makes the cough very less tiring. So some of the bronchial secretion enhancers include sodium and potassium citrate, potassium iodide, guaifenesin, Vasaka, ammonium chloride, etc. There are many drugs. We can remember at least 2 or 3. The mucolytics include bromhexin, ambroxol, acetylcysteine and carbocisteine. So the bronchodilators, which we saw, those drugs that are used for asthma, they can also be used along with cough when the cough has associated bronchial hypersensitivity. So the dilators that can be used are salbutamol or terbutaline. It relieves cough that results from bronchospasm. Mucolytics like bromhexin, it's a potent mucolytic and mucokinetic. It induces copious bronchial secretions. It is useful if mucus plugs. If the mucus plugs up, that means dried up secretions inside the bronchial tree. It is very useful if mucus plugs are present. But the side effects include rhinorrhea, lacrimation, gastric irritation and hypersensitivity. Why? Because it increases the secretions, it's going to cause rhinorrhea and lacrimation. To summarize, bronchodilators are those drugs that are given for treating asthma. It includes beta agonists, methylxanthines, and anticholinergics. Those drugs that act on the bronchial smooth muscle. Antitussives are those drugs that used for dry cough. They suppress cough. Okay. So there can be 3 categories: opioid, non-opioid, and antihistamines, H1 antihistamines. Okay. So these can be given. Expectorants are those drugs that are used in productive cough, which expel the mucus secretions. Some of the drugs include bromhexin. That's all for the drugs that are used for the management of asthma and cough.